Hi everyone, my name is Luke Edgar and I'm one of the first year family medicine emergency medicine residents working here at the St. John Regional. I'm making this video today to tell you about a quality improvement project that I'm working on with Dr. Rachel Goss and Dr. Kavish Chandra. The project is aimed at improving the quality of care that we provide hip fracture patients in our emergency department. We plan to use a technique called the fascia iliaca compartment block to treat patients' pain while they're waiting for their definitive surgery to treat their hip fractures. The fascia iliaca compartment block is a regional anesthetic technique used as an opioid-sparing pain management strategy for hip fracture patients. With a single injection, sensation to the femoral nerve, lateral femoral cutaneous nerve, and obturator nerves can be blocked. This is done by injecting a large amount of dilute anesthetic into the potential space just below the fascia iliaca, lateral to the femoral nerve. Local anesthetic spreads along the fascial plane to reach these three nerves. Two systematic reviews of this technique were conducted in 2014, one of which was authored by our own department head, Dr. Atkinson. These studies found that the fascia iliaca compartment block both reduced pain and the amount of opioids required to achieve pain control. By limiting opioid use, we hope to reduce opioid complications such as respiratory depression, oversedation, and delirium. Additionally, by treating pain at the source, we hope to achieve better pain control with patient movement than would be possible with opioids alone. To help our patients and make this change in practice successful, we need your help. Some physicians in our department will use a two-person technique to perform a fascia iliaca compartment block. These physicians will ask for your help once they have set up their supplies and ultrasound machine. They will pass you a syringe of local anesthetic and, while maintaining their own sterility, pass you tubing to connect to the syringe. After connecting the tubing, you will be asked to flush the line. The physician will use ultrasound guidance to place the needle in the correct location, then ask you to aspirate and inject a small amount of local anesthetic. If they are happy with where they see the local anesthetic spreading on the ultrasound screen, they will continue asking you to aspirate and inject aliquots of local anesthetic until a total of 20 to 40 cc's of local anesthetic has been injected, noting that the volume may change depending on the patient's weight and the type of local anesthetic selected by the physician. The most common choice you may see used is 30 cc's of 0.25% bupivacaine. After the procedure, the physician will mark on the leg which they have injected and document their procedure on a new physician document. There are two rare but serious complications of the fascia iliaca compartment block to be aware of. The first is opioid toxicity. In instances where patients have received opioids before their fascia iliaca compartment block, the block may work so well that their pain sensation is completely removed, such that the dose of opioid they received is now too high and their respiratory rate drops, and they become oversedated due to opioid toxicity. The second rare but serious complication is local anesthetic systemic toxicity, or LAST. This complication can happen after inadvertent injection of local anesthetic directly into an artery or vein. Frequent aspiration checks on your part during injection of medication can help to prevent this complication. The signs and symptoms of this toxicity are neurologic and cardiovascular in nature. Neurologically, patients may develop facial tingling, perioral numbness, a metallic taste, and tinnitus, which progress to altered level of consciousness and seizure. From a cardiovascular standpoint, patients may develop hypertension and tachycardia initially, followed by hypotension, arrhythmias, and even cardiac arrest. Due to these two rare but serious complications, patients require close monitoring for the first half hour after a fascia iliaca compartment block. They should have a set of vitals including heart rate, blood pressure, respiratory rate, O2 sat, GCS, and pain score at 0, 5, 15, and 30 minutes post-procedurally. While there is a place for vital monitoring on the new physician document, these vital signs can be documented on the patient's regular flow sheet. Abnormal vital signs should be reported to the physician managing the patient's care so that they can be assessed further for opioid toxicity or local anesthetic systemic toxicity. If local anesthetic systemic toxicity occurs, anticipate an order for Intralipid, which is located in the white medication cabinet in trauma room 19. To review, hip fractures are a common and painful condition diagnosed in elderly patients in our emergency department. The fascia iliaca compartment block can help treat this pain and reduce the amount of opioid medications required. You can help facilitate this process by acting as an assistant to physicians for the procedure and monitoring vitals at 0, 5, 10, 15, and 30 minutes post-procedurally as a screen for rare but serious complications such as opioid toxicity and local anesthetic systemic toxicity. Thanks for listening, and please don't hesitate to reach out to Luke Edgar at luke.edgar@dal.ca or Rachel Goss for further information about this initiative.